Rahim. I have been asked to give a very brief talk about the basics of diabetic nephropathy and how this diabetes affects the kidneys. It's going to be a kind of core knowledge, and I'm not going to present here any studies or any research, but it's just core knowledge that I think we all need to understand. I'm grateful to the organizers of DOCTORSCON, Professor Altaf Cheema Saab, Dr. Aftab Iqbal Saab, and all others for arranging such a successful gathering. I think we are already behind the schedule and we have so many things and some speakers are waiting. So I will talk about diabetic nephropathy. And diabetic nephropathy, basically, every patient with diabetes at the time of diagnosis of diabetes is in stage 1 of kidney disease. This is a stage of hypertrophy and hyperfiltration. Because of glucagon, because of growth hormone, because of hyperglycemia, the patients hyperfilter and they have glycosuria. So in this stage, their GFR is, which is normally 100 average, the GFR increases to 150, 160 per minute. So there's a super normal GFR. So this is the stage of hypertrophy and hyperfiltration. The second stage of kidney disease due to diabetes is stage 2 nephropathy, which is called silent stage. And now over the years, the kidney function is gradually going back to normal. From a supernormal, it is going to normal. And the kidney size, which was initially bigger, could now become normal. So this is called silent stage. And then we have stage 3, which is again another 5 to 7 years down the road, that patients, if their glucose is not well controlled, go into microalbuminuria. Now, normally a person is excreting about 20 milligrams of albumin, every person, and then if you include all the proteins, the tubular proteins, stem, horsefall protein, etc., then the normal urinary protein is about 150 milligrams in 24 hours, which a normal person excretes in the urine. And when the urine protein leakage is, or urine albumin excretion is more than 30 to 300 milligrams, then we call it the stage of microalbuminuria. And remember that the proteinuria, that the dipstick, that when we test the urine, the dipstick only picks up proteinuria when it is more than 500 milligrams. So that means many patients you will find that they have no proteinuria on dipstick, but if you test for microalbuminuria, you will find protein in the urine. So this is stage 3. This basically indicates that there is endothelial dysfunction. The blood vessels have been damaged. There is more leakage. And when this endothelium of the microcirculation is affected, you expect the microcirculation of other organs to be also affected. So people say that proteinuria is a window to the diagnosis of silent coronary artery disease. That if a diabetic patient has proteinuria, it is likely that he has an underlying ischemic heart disease, which can only be tested through other investigations, or unless proved otherwise. The fourth stage is that of overt proteinuria, when the patient has more than 500 milligrams protein in the urine, and it goes on. Now, at this stage, the GFR may tend to fall now. So from 110 to just 70 is early, and if the GFR is between 70 and 30, it is intermediate, and when it is between 30 and 50, it is called late stage 4. So every patient that you come across with diabetes is at least stage 1, because even if his GFR is normal, he is hyperfiltering and he's got hypertrophy of the organs. Stage 5 is that stage when the GFR is less than 15, and we call it end-stage kidney disease, or CKD 5. When patient cannot sustain life without the help of dialysis, then it is called end-stage kidney disease. Now in stage 1, you will see that there the GFR is supernormal, the kidneys are increased in size, there is increased glomerular size, and it is present at the time of diagnosis. The stage 2 is the silent stage, which is the stage of hyperfiltration, and then this hyperfiltration starts to decline to normal. And then intermittent microalbuminuria may occur, and then you may find under the microscope some mesangial expansion. Mesangium is that part of the glomerulus which supports the capillaries. It is the stalk which supports the capillaries, and this is actually an active component of the renal glomerulus. And then this mesangial expansion, and gradually the glomerular basement membrane starts to thicken. And you can see those wire loops that they are getting thicker in these areas. And then it takes about 5 to 7 years to develop this stage. The third stage is that of microalbuminuria, and now you have persistent microalbuminuria. Mesangial expansion is there. You can see this reddish part. This is the mesangium. Glomerular basement membrane begins to thicken, and retinopathy starts. So the same kind of arterioles that you see in the kidney, you also see them in the retina. And if you do a fundoscopy and you find retinopathy there, it is very likely that this patient has now developed kidney disease also. So you can diagnose nephropathy through the retina by looking at the dilated fundus. And it may take 7 to 15 years for diabetes to progress. In stage 4, there is obviously clear-cut macroalbuminuria and albuminuria, and the GFR is now beginning to fall. There is glomerulosclerosis. You can see this now. This is a nodule formation. Afferent and efferent arterioles are thickened, and it takes about 15 to 20 years of diabetes. There is frank hypertension now, and the patient has vasculopathy and neuropathy evident. The stage 5 is the last stage. Now you can see these Kimmel-Steele-Wilson lesions, these nodules, or diffuse glomerulosclerosis, and GFR is now down to 15. So when we say what is chronic kidney disease, we should be very clear in our mind. What does this definition mean? It means that the kidney damage has been for more than 3 months. So if a patient comes to you and he carries a report which is more than 3 months old, and the creatinine was found elevated, well, you will label this patient as chronic kidney disease. Or if there's a very long history and you are sure that even 3 months ago the patient had elevated creatinine. But if it is 1 month old and previously the reports were normal, then it doesn't fall in the category of CKD. Then it falls in the category of acute kidney injury. So GFR less than 60 for more than 3 months with or without kidney damage, you will see some of the reports from good labs, and they show that the normal GFR should be more than 60 mils. Actually, the normal GFR is 100 to 120. But if it is below 60, then you start calling it renal impairment or renal failure. Or if you have microalbuminuria, or if you have persistent proteinuria or persistent hematuria, then it is also called chronic kidney disease with normal kidney function. You could have that with normal kidney function. So any structural or functional abnormality or any abnormality in the urine which are persisting for more than 3 months, even with a normal serum creatinine, will fall in the category of CKD. So any structure, for example, a person has perfect kidney function, you do an ultrasound, you find polycystic kidneys. Well, you will label this patient as chronic kidney disease. No matter his creatinine may be totally normal, his urea may be totally normal. So any structural abnormality, a patient had a kidney transplant, his native kidneys were destroyed and he has a kidney transplant and this transplant is working fine. Even then you will label that patient as CKD. We call it CKD-T, that is CKD after a transplantation. So this shows the different grades, grade 1 of renal insufficiency. When you have that structural damage, but the GFR is more than 90, or between 60 and 90 it is 2, then we divide this 3 into 2 categories, A and B. A is when 45 to 59, and B when 30 to 45. So we have, for convenience, divided stage 3 into A and B. And then stage 4, when there is severely decreased kidney function, 15 to 29, and kidney failure when it is less than 15. Now this side shows the degree of albuminuria, that higher the albuminuria, for example, if it is 20 microgram, less than 30 milligram per gram of, we take this ratio with gram of creatinine, or if it is between 30 and 300 or more than 300, we call it A1, A2 and A3. And these colors show that how much is the risk. This is mild risk, this is moderate risk, this is orange is severe risk, and this is very high risk of progression of kidney disease. So a patient may be in G3A and could be A1. So you will write down CKD G3A A1. So the person will know, the other doctor will know that what stage this patient is suffering. Or a patient may be G5 and A3, which is very advanced disease. So that is how the grading of chronic kidney disease is done, and it holds true for all diabetics also. Now we're talking about GFR, but what is GFR? GFR, you can now calculate, and there are complex formulas. This is called Cockcroft-Gault formula, which is if you take the age of the person and 140 minus age in years into weight in kilograms divided by 72 into the serum creatinine of that person. So, and if it is a female, you take 85% value of that. This is an easy way of calculating the GFR. And then there is an MDRD equation, which is a bit complex, and then there is the CKD API, and different formulas are there. But now the life has become much easier with the help of these eGFR calculators, which you can, on your smartphone, you can download from the Apple Store, you can, or from other sources, you can download these. So in this, all you have to do is put the patient's creatinine and the age and the gender. And you just press this button and it gives you the GFR of that person. So I think this modern era, no patient should walk out of your clinic without having his GFR been calculated, so that you can plan your strategies of treatment accordingly. So whenever patient comes with kidney disease, calculate this GFR. It is so simple. Just download this application and put the creatinine and age and gender, and it will be automatically calculated for you. This is another application, eGFR calculator. You put the age, creatinine, gender, you press. So I've just brought these so you get familiar when you go onto the Apple Store or Google Store. So once a patient has developed chronic kidney disease, all the functions that the normal kidney does is that it regulates the sodium and water metabolism and the potassium metabolism and eliminates nitrogenous waste, produces erythropoietin, corrects the acid-base balance, and activates vitamin D into active form and the phosphate elimination. So if these things are not happening, it will lead to hypertension, and this hypertension can lead to heart failure. And if there is increased vascular volume, it will lead to edema, hyperkalemia, uremia, coagulation problems, anemia, acidosis, activation of vitamin D is not happening, so renal bone disease will occur. So all these, you will find that the majority of these symptoms are arising outside the kidneys. So we come across patients very frequently who have been treated for hypertension for years without having known that the cause of hypertension was chronic kidney disease. Similarly, patients may come with edema of the feet and may be labeled as heart failure or may be labeled as liver disease without having known what the patient's GFR is and how much is the proteinuria. Similarly, electrolyte imbalance may be attributed to drugs or dietary indiscretion. Patient becomes anemic. The first knee-jerk reflex is कि इसका जिगर काम नहीं कर रहा, इसका जिगर खून नहीं बना रहा, हालांकि खून तो किडनीज बनाते हैं. So we forget that all these functions, all these problems, pericarditis, the patient will land with the cardiologist for pericarditis, for precordial pain. Patient may have pruritus and may end up with dermatologist getting treatment for pruritus without having known that has CKD, or may come with bleeding because of different platelets dysfunctions. So impaired immune response, skin disorders, GI disturbances, patient may come with nausea, vomiting, anorexia, and may be treated with PPIs and antiemetics without having known. So it is very, very important that every patient who comes to you with diabetes or with hypertension, you must look at the kidneys, you must do the creatinine, and you must know the patient's CBC and electrolytes. So these are the symptoms and these are the complications. If we talk about the renal bone disease alone, we have many types of bone diseases. This is a typical rugger jersey spine. You look at this shirt and it resembles like that. Or there is resorption of the bone, or there is extra osseous calcification, or there may be brown tumors in the bones. So how to manage these patients with diabetes? If they have microalbuminuria, look at the glucose control. Is it adequate? If not, then manage the glucose control. If the blood pressure is more and there is proteinuria, you need to start an ACE inhibitor or an angiotensin receptor blocker. And if the creatinine is more than 3, then, and these ACE inhibitors and ARBs are not working, then you may have to add a non-dihydropyridine calcium channel blocker, or then you have to do additional workup. But important thing is that at microalbuminuria stage, as we said, it indicates endothelial dysfunction. We need to look for eye disease, monitor the creatinine, search for heart disease, optimize blood pressure, optimize lipids and glucose, discourage smoking, and screen for vascular disease and investigate for other renal diseases which could be responsible for this. This diagram is important because it tells you the afferent and the efferent arteriole normal in the glomerulus, and in diabetes there is efferent arteriolar vasoconstriction, which increases the filtration pressure here and more protein leaks into the tubules. But if you give an ACE inhibitor or an ARB, you selectively vasodilate the efferent arteriole, resulting in decrease in the filtration pressure and less proteinuria downstairs and less leakage into the mesengium, because proteinuria is a marker of damage to the kidneys. Now, the anti-diabetic drugs, and I think metformin, when you are treating these patients, you should give it, you should continue it till the GFR is down up to 40 or 45. And if you want to do a contrast study like angiography, you have to stop it. But if it is below 30, then you have to stop it, or you don't initiate if the patient comes to you with GFR less than 30. Sulfonylureas are likely to give rise to hypoglycemia because of their long action. DTP4 inhibitors, these two are pretty much safe. They don't require any dose adjustment. The sitagliptin, saxagliptin, they require some modification in dose. Pioglitazone requires no dose adjustment. But as you heard in the morning, that it could cause edema and retention and is not recommended in heart failure patients. Similarly, patients who already have fluid overload, you should try to avoid pioglitazone. SGLT2 inhibitors, dapagliflozin and empagliflozin can be used, and now the recommendations are getting further down that you can continue up to 20 ml GFR. If up to 20 you can continue, and you can take it through towards end-stage renal disease if the patient was already taking it. GLP-1 antagonist, exenatide, there is a caution. You have to stop. The dulaglutide and semaglutide, they require no adjustment. And they are beneficial as they help the kidney also. So what is the treatment for patients who have progressed to end-stage kidney disease? Hemodialysis or peritoneal dialysis, and the indications of initiating dialysis are nausea, vomiting, uremic encephalopathy, volume overload, hyperkalemia, metabolic acidosis, or pericarditis. Or you can do peritoneal dialysis, that a catheter is placed in the belly and this fluid is then drained out. So the peritoneum membrane acts as a dialyzer, and you put in clean solution and take out the dirty solution. And patients who have ambulatory problems cannot come to the dialysis center. They can have this at home, and now there are machines available which can automatically do this bloodless dialysis. This has to be a continuous process, and you have to exchange 3 or 4 bags of PD to do this. And patients, selected patients who do not have advanced liver or coronary disease, or who have no other contraindications, you put a third kidney without removing the native kidneys. You can put a third kidney close to the bladder, anastomose the artery to the iliac and to the vein, and put the ureter through a new hole in the bladder. And of course, with immunosuppression, triple immunosuppression therapy, mycophenolate, tacrolimus, and steroids, these patients can have a normal lifestyle. So this is my last slide, which only says that 10 things you have to remember in a diabetic patient. First is the diagnosis should be correct, because diabetic patients are not immune to having other kidney diseases. So there could be a patient with diabetes with a superimposed crescentic nephritis, or with IgA nephropathy, or with analgesic-induced damage. So your diagnosis of diabetic nephropathy should be firm, and other causes of kidney disease excluded. Many a times patient may come with massive proteinuria, long history of diabetes, and you find out that the kidney was not affected by diabetes but by amyloidosis or by membranous nephropathy. So blood sugar control, blood pressure control, proteinuria reduction with ACE inhibitors, ARBs, non-dihydropyridine, or with SGLT2. Silent heart disease must be looked at, aspirin, smoking cessation, and lipids. Anemia management with iron and erythropoietin, renal bone disease, vascular access for dialysis. When the GFR is down to 20, you should establish a vascular access, a fistula, and dialysis or transplant depending upon the patient selection by you. And of course, what drugs patient has to avoid: all nephrotoxic drugs, NSAIDs, And if the ACE inhibitors or ARBs are causing worsening, then you don't give that. And diet which is moderate in protein intake, which is moderate in phosphates like dairy products, and diet which is low in potassium, these are the things that you want to give to the patient. Thank you very much.